Dr. Andrew Yun at USC Orthopaedics, and today we're going to talk about how we evaluate and then correct an acquired leg length discrepancy after a prior total hip replacement. This is a challenging concern. Sometimes after hip replacement, a patient is made longer and a patient may feel uneven when standing or walking and may require a shoe lift. Our goal in this talk is to discuss how we measure that difference and then how we plan a correction for that so a patient feels more even and more symmetric. In this case, there are two central issues on the right side and on the left side. On the right side, the patient has an arthritic hip joint with loss of joint space, inferior osteophytes at the femoral head-neck junction, joint space narrowing. This hip has pain, loss of function, and weakness. On the left side, the patient has already come to us having had a hip replacement. The patient is complaining that although the leg feels better, the leg also feels about 1 centimeter longer. The patient wears a shoe lift on this side, which helps but feels it is inconvenient. Our plan is to fix the arthritic right hip and at the same time correct the overall imbalance so that the two legs match in length as closely as possible. This will require careful measurement through templating and a strategy to achieve the planned length while preserving stability and normal muscle mechanics on this side. Good decisions will depend on having accurate information and accurate measurements. So in the operating room, we obtain a calibrated radiograph using a metal ball marker of known size. And this allows us to correct for magnification precisely. We then position the pelvis neutrally so the pubic symphysis aligns with the coccyx, the obturator foramina are symmetric, the ischial tuberosities are level. We place both legs in the same position and in the same rotation. And then this standardized setup allows us to compare the left side and the right side accurately, predictably, and easily. Now, with the pelvis level and the legs symmetrically positioned, we measure from a reliable pelvic landmark to a femoral landmark. The convention is to draw a horizontal line across the teardrops on the pelvis. From that line, we drop a perpendicular line to the top of the lesser trochanter. In this study, the left side has a measurement of 41 millimeters, and the arthritic right side has a measurement of 32 millimeters, which equals a 9 millimeter discrepancy, and is very similar to the 1 centimeter discrepancy or 10 millimeter discrepancy that the patient feels. In this hip, while we fix the hip, the clinical goal will be to add an additional 9 millimeters of length to this right side so that both sides at the end measure 41 millimeters on the postoperative film. Now that we know the discrepancy, we can template on how we can achieve the additional 9 millimeters safely and predictably. First thing that we'll do is we'll plan the acetabular socket. We position this within the bony acetabulum. We medialize it to Kohler's line and that we ensure that we have appropriate bony coverage all the way around in all three zones. This identifies our center of rotation. We then plan a stem that fits neutrally down the canal and then gives us a new center of rotation. This difference will then be 9 millimeters. When this matches up with this, we will have restored an additional 9 millimeters of length predictably. Once we have placed our components, we will take preliminary measurements. This is the right side, this is the prior left side. We've placed our acetabulum in the proper position. We've looked at abduction and version. We have our stem that's neutral down the canal and at the height that we have planned that restores our length. And then we qualitatively look at the stem. We have a neutral pelvis, we have a vertical line, we have the convention of the horizontal line across the teardrops, and then we have marked the amount. Run these measurements through our computer software like we did in the beginning. Remember, we had an initial target of 41 and a starting discrepancy of 32. We plan to add 9 millimeters of height. We can see we have a neutral pelvis, vertical line, horizontal line, and now on this side we have the original 41 millimeters, but we restored 9 millimeters of height, and now we have 41 millimeters on both sides, thus restoring hip length as well as offset symmetry. So this is our final construct, our right hip, We see the bone is intact, stem is neutral down the canal, the cups at the correct angle, ball is turned nicely in the socket, but most importantly, we've also been able to restore the deficient length missing on this side compared to this side. And now with the neutral pelvis, the patient has equivalent hip length and symmetry and will no longer require a shoe lift or notice any asymmetry on one side compared to the other. Thank you very much.